to Moyale town, Marsabit County, is a traveler's dream come true. Smooth tarmac, a far cry from what some Kenyans know. Bumpy roads punctuated with potholes and a rumor of tarmac here and there. Not your Isiolo Moyale highway that allows one to enjoy the vast emptiness of the scenery that is Chalbi Desert. Sparsely populated, you will occasionally spot herders and their camels living their lives as they know it. Their lives is a mix of the beauty of this same expanse and an ugly side that disproportionately disadvantages women and girls. Marsabit is one of the largest counties in Kenya. The biggest town is Moyale, right at the border with Ethiopia to the north. A predominantly Muslim region with just over 450,000 people as per the 2019 census, women make up less than half of the population, 216,000. Marsabit Counties is one of the largest counties in Kenya by area, but it records one of the lowest deliveries by skilled birth attendants. This is 1 in every 4 pregnant women. It is these women that know all too well what it means to be on the receiving end of a poor health system and deep-seated cultural practices. Hadija Godana is a 45-year-old mother of 3 living children and 1 who died during childbirth. Her eldest is 20 and the youngest 13, all delivered at home, at times with a traditional birth attendant present.
The hospital was far from where I lived. I also did not think they would help me any differently. So the traditional birth attendant helped us.
But it is one child, her 3rd pregnancy, that she lost her dignity and mental well-being.
I called the traditional birth attendant when I went into labor. But I think she did not support me well during the delivery, and that is how I got that problem of urine leaking. I think it's because she was old, unlike other younger ones that had helped me deliver before. After that, I could not control my urine.
For 10 years, Khadija lived with the mental anguish of having an obstetric fistula, one of the preventable complications of childbirth. Anytime she stood up from sitting, urine would leak.
Getting out from the house to the latrine for a short call was a big problem. I will not get there without the urine leaking. This was very embarrassing and humanizing. After every urine leak, I had just to go and clean up. I was afraid of sharing my problem because of stigma. But when I had community health volunteers saying there are doctors coming, I agreed to get help.
Apart from her husband, who she says supported her, Khadija did not tell a soul what she was going through. In 2019, Khadija was lucky to be a beneficiary of a free surgical camp that saw her fistula repaired through the Safe Motherhood Project by AMREF Kenya. The focus of this project is on women's health in order to reduce maternal mortality and morbidity.
Now I have no leakage of urine at all. I can do my housework, go fetch water and firewood, meet people, and not be afraid of any leakage.
30-year-old Sadia Hussein, who lives just at the outskirts of Moyale town, is one of the beneficiaries of the free fistula repair camps. Jovial and full of life, the fistula she had almost crushed the soul of this widow and a mother of 2 children, aged 13 and 8 years.
Mimba ilikuwa mzuri na nilipata delivery na ulinipeleka hospitali. nilienda hospitali ya Moyale. Sikuwa mimi naishi nini Oda. Siku hapa niliishi Oda na nimepeleka hospitali na daktari wameniweka mkono kwa ndani karibu watu 7, daktari 7. Amesema hizo toto ni siwezi kufanya nini bila operation. Aliniandikia referral Sololo Hospital. Alinifanyia kwa Sololo Hospital operation. Na nilifanyia operation, hiyo kijana nilizaa na nililala siku 2 ile mkojo ulitokea. Na baadaye nilikaa huko miezi 3 hospitali ya Sololo, nililala miezi 3 huko. Na alinifanyia daktari repair huko ndani. Na nilirudi nyumbani. Nikarudi nyumbani nilikaa kama miaka 2 hivi. Na hii kitu inatokea tu. Nikikaa natokea. Nikitembea natokea.
It was the seemingly unending referrals from one hospital to the other or one doctor to the next that made her despair.
Nilienda huko Nyeri, hospitali ya Nyeri, alinifanyia huko. Nililala huko karibu mwezi 2 huko na nirudi hapa Moyale. Sijua na nilirudi hapa Moyale. Na hiyo sio kama 2 natoka tu mkojo natoka. Hata nilienda hospitali ya Nairobi. Nilipata matibabu mengine niende huko. Hata alinifanyia huko Nairobi. Nilirudi hapa. Unatokea tu. Na baadaye hao madaktari walinieleza, madaktari wamekuja wa Amref. Na aliniambia huyo madaktari wa community health workers alikuja kunieleza. Na nilienda. Mbeleni walinifanyia operation 5.
On the 2nd day of April 2019, her life changed with one final and 6th surgery that restored her dignity.
Sasa nimekuwa mzuri kama mbeleni kama ambaye ni msichana umezaliwa. Sasa niko poa na nimepongeza nyinyi kila mtu, asanteni. Na nitamweleza watu wengine kama ambaye kuna shida ya kitu ya fistula, usiogope, ujitokeze uende hospitali usaidizi upate huko.
Sadia had withdrawn to solitude after being ridiculed, unable to cope with the stigma that came with walking around with leaking urine.
Siku hiyo nikisimama hivi anatoka anatiririka. Siwezi kukaa, anatoka tu. Siwezi kutembea. Hata nikifanya niliweka pads 1 2 anatoka tu ndani. Kabisa nilikata roho na nasikia vibaya sana. Nasikia tu uzuri kukaa tu kwa nyumba. Kuna watu wetu wengine wanakaa huko. Wanaeleza mtu mwingine mambo ya msichana mpaka saa hii mkojo anatoka huko ndani. Tunasikia ukiwezi mama hivi tunasikia harufu vibaya huko ndani. Na akanielezea na mimi nikakata roho nikaleta kwa nyumba.
The project that offered Sadia and Khadija a new lease of life identifies gaps in the healthcare system and develops practical solutions like the free fistula repairs that change the trajectory of women's lives and livelihoods.
Sasa naanza biashara kidogo nauza kitu kama mboga, viazi, kama mafuta taa. Nafanya na ninunua na hiyo watoto wangu chakula na fees wa shule.
Tell us about obstetric fistulas. What are they and how do they come about?
This is a complication that mostly arises as a result of labor and delivery, whereby there's a hole which comes up and there's a communication either between the birth canal and the bladder, or the birth canal and the rectum. So what eventually results, if there's a communication, then that means this gland will continuously leak either urine or stool or both. Remember, when God created us as humans, then he put brakes, he put sphincters. If I feel like the bladder is full, I'll go to the washroom. If I feel like my rectum is full, I'll go to the washroom. But here there's continuous leakage. Any urine that goes to the bladder, it it comes out. Any stool that goes to the rectum, it comes out. So you can imagine the kind of miserable life that this patient will live. Mostly, this is as a result of what we call prolonged obstructed labor. Labor is supposed to be a natural process, and so for most women, labor will come up, they'll go to hospital, they'll be assisted by the midwives or the doctors, and they'll be able to deliver well. But there's a select few of patients who, due to one reason or another, maybe the baby is too big or the pelvis is a bit small, they're not able to deliver normally. And so these are the kind of women who ideally will need to go to theater for what we call cesarean section. Now, if that cesarean section is not offered in time, if the accessibility is not there, maybe the patient opts to deliver at home, or the access from wherever they stay to the hospital is far, or maybe because of funding they're not able to afford to come to the hospital, then yes, this is what will result. They'll attempt to deliver at home, and there'll be the head as it descends. It will compress the bladder, it will compress the rectum, and eventually it will leave a hole. So that is the commonest cause of obstetric fistula. Now, we have other causes. Of late, we are having cases of probably surgeries that have been done, pelvic surgeries that have been done, and due to one reason or another, then there's injury to the bladder or there's injury to the rectum. We have women who probably have fibroids and they're being done surgery where the uterus is being removed. We have women who also maybe they're being done cesarean section by, probably doctors that are not well qualified. And these ultimately, when they injure the bladder or they injure the rectum, then the same problem ensues where they leak either urine or they leak stool continuously. We have, especially when you go to the rural areas where, girls like climbing trees, sometimes they fall off trees, and when they fall on branches, then there's trauma to the perineal region, and that can also result into fistula. We have, with what we call gender-based violence, we have sometimes small girls who are assaulted sexually by adults, and we have seen quite a number of these who also end up getting fistula. And this is also very bad because these are very young girls, and just the fact that they are assaulted by an adult and they lead to this, which if it's not addressed, then it becomes a lifelong problem. It's a disease of the poor. And remember I mentioned to you that the women who end up getting fistula, majority of them, they ought to have been taken into theater for cesarean section. But these are women who they probably live in very remote areas, or they are not able to access healthcare in time, or even if there is accessibility, but they do not have the funding, for them to come to hospital early enough. Coupled with the fact that, deep in the rural areas, there are a lot of cultural misconceptions, where probably the community will encourage women to try and deliver at home. The community will encourage women to try and deliver at a traditional birth attendance place. So majority of these women, unfortunately, they are poor. When they get fistula, chances of them getting access to care, again, is limited because of the same reasons. Either they don't have the funding, facilities are very far, and remember in this country, as we speak, we have very, very few fistula surgeons. So, and they cover this whole population of 47, 48 million. So getting that patient from where they are to go and look for a fistula surgeon, again, it's very hard. And so we find these women who have lived with fistula, 5 years, 10 years. Recently, we had a woman who had stayed with the fistula for around 27 years. And there's help available, but either they didn't know or, just that accessibility is a big problem. When it comes to diagnosis, we have to combine what we call a history taking. So we listen to the woman's story. Then we have to actually do a thorough physical examination. And where there is need, we have to actually do other laboratory investigation or radiology, including ultrasound and whatnot. Typically, a woman with fistula will have a complaint of either leaking urine or leaking stool. Because when I'm seated in front of a patient who is leaking urine and who is leaking stool, there's usually a characteristic stench. And so as they're telling you the story, a lot of time in your mind, you are making up your mind, it's likely urine, because the stench continuously follows them. When we examine, we most of the time do what we call a dye test. So we put a urine catheter in the bladder, and then we infiltrate some dye. There's a special dye called methylene blue. So as we are infiltrating the dye into the bladder, we are checking the birth canal. We are checking physically in the birth canal. If there's any hole, as the dye is going into the bladder, then there'll be leakage. You'll actually just see directly leaking from a specific point. So if we put in like 60 mils, if there's nothing, then we add, then we keep adding. As we are adding, we'll tell this woman to keep coughing, because when they cough, they exert pressure on the bladder. And if there's a fistula, we'll be able to clearly see it. And we do this still for the, for the rectovaginal fistula. Rectovaginal fistula, it's a bit easier to see, because usually when you just put the woman on the couch and you examine, you are likely able to see. This is a physical defect, and a physical defect can only be fixed through surgery. So I would say like 99.9% of patients with fistula, obstetric fistula, either for urine or for stool, they will end up needing surgery. But it's also a mental disease. Because of the kind of symptoms these patients have, they live in depression, some may be separated, they are divorced. They are very much set apart from the social environment. And so they have very low self-esteem. These are patients who will not mingle with other people. And so for us as fistula surgeons, when we find them, we go beyond just treating, beyond doing the surgery. Because having learned the skill, performing the surgery, because of my experience, is relatively easy. I can do maybe 1 hour, 2 hours, 3 hours, and I'm done. But we need to treat the mind. This patient is still living in depression. We need to find how can they be reintegrated into the society. And so what we do when we do camps, we spend a lot of time counseling these patients. We can let a woman stay in the hospital even for a whole month, as we do continuous psychological counseling, involving professionals, just to make sure that these women, when they go back home, they're cured not just physically, but also mentally. They feel like, I am still part of the community. As we speak right now in this country, we are about 12 active fistula surgeons. 12 active fistula surgeons. So that means one fistula surgeon for a population of about 4 million. Yeah. So, and it's really tough. I mean, getting the skill is not easy. You have to spend quite a number of years just learning the skill, perfecting it before you go out there and you say, I'm a fistula surgeon. It's a difficult skill to learn. We have specific referral centers, regional, whereby a patient with fistula will be sent to this region. This region, most of them, these areas, they have a fistula surgeon who is stationed there. And, on a routine basis, when they get patients, they'll be able to repair them. Remember, we mentioned it's a disease of the poor. And so previously it was very difficult for these centers because they lacked any sort of financial support. But with the help of the government, with the help of some specific NGOs, they have come up and chosen to support specific centers. So they reimburse the hospital basically for the supplies, for the expertise in one way or another, so that the hospital can also keep afloat. So the main hospital in this country is actually based in Eldoret. It's called Gynocare Fistula Center. It's the main referral center in this, not just in this country, but in this region, because we get patients referred from all the way from Uganda, Congo, Burundi, Rwanda, coming to this Gynocare. And even regionally in the country, when those of us who do fistulas and we find a very, very complex surgeries that we cannot do, we still refer to these areas. Moving on from Eldoret, we have one in Kitale called Cherengani Nursing Home, again very effective. In Kisii, we have what we call Kisii Gynocare, again an offshoot of the Gynocare in Eldoret, very effective. We have Kisumu District Hospital, the fistula surgeon there, and so they do continuous surgeries. Then in Nairobi, of course, we have Kenyatta National Hospital. That I would say is like the parent, where most of us learn the skill and then we've gone on to practice in other areas. Still in Nairobi, we have Jamaa Mission Hospital, again supported by one of the NGOs. Then down the coast, we have what we call Bomu Hospital. So these are the areas where any patient, any fistula patient, wherever they are, if they're able to access this facility, they're able to get treatment. Fistula is a conglomeration of many, many things. that start with poverty, early marriages, lack of family planning, early childbearing, FGM. Eventually, they culminate into fistula. So in our minds, fistula is a symptom of many things that have not gone right. Yet, so as a fistula surgeon, I will be able to treat the fistula, but I'm not addressing the factors leading to the fistula. How can we address it? Keep girls in school. Remember, in some areas, it's very hard because part of what accelerates fistula is that there are lots of myths about fistula. So women will be told, for example, that you got this fistula because you are unfaithful to your husband when you're pregnant. So if that sticks in the mind, it's very difficult even when this woman goes back to the community. So we spend a lot of time just trying to figure out how best can we address them. Now, in some of those fistula centers where they do continuous fistula surgeries, what they do is they have an extensive rehabilitation program, whereby these women after repair, some of them can be trained on some specific skills, maybe tailoring, maybe computers, something that when they go back to the community, they can find a way of at least, earning a living, despite the fact that they had these and probably they're separated. Economically, they are empowered. When they go back, they realize they're a bit helpful and they can be able to support themselves and their families. And I'm really happy and glad about the government program of free primary education, because in these areas where girls never used to go to school, now they're going to school. When a girl is in school, they are not likely to get married early, they are not likely to get children early, they're likely to use family planning, they're likely to have a sizable family size. You get? And communities that have embraced girl child education, you're not likely to have them getting fistula. So keep girls in school to prevent majority of this problem that eventually lead to fistula. Plus, a girl who is educated, perchance they get fistula, it's much easier for them to access treatment. The biggest challenge we have is, I mentioned to you, these are diseases of the poor. So I, as a fistula surgeon, I'll put in lots and lots of hours, time, money, emotions, learning this skill. What will be the returns? Probably zero. And so that's why we have very few fistula surgeons. It's a disease of the poor. The poor will not pay me. So the 12 of us who are doing this, as a matter of fact, majority of the time, we are doing it on volunteer basis. We are doing it just to help the women, and we do it because we know if we don't do it, then who will do it? These are our mothers, these are our sisters, these are our aunties, our neighbors. If I don't do it for them, who will do it? Yeah, so we do it basically for volunteer basis, but we'll find a lot of us still, we have areas of employment, so we do this as part of just the social responsibility as human beings.